We will discuss here some topics relevant to psychiatry in the pediatric setting. Our major changes to the DSM-5, probably most prominently, is the fact that we've changed the name of mental retardation to intellectual disability. I'm not exactly sure why they did this, other than that for political reasons. So the World Health Organization changed the name to intellectual disability and then subsequently intellectual development disorder. Intellectual developmental disorder, however, has not been enacted until the adoption of the ICD-11. So the DSM decided to just put that in parentheses next to intellectual disability to just sort of bridge it to the future. Other things that we know now and that we have sort of codified into the DSM-5 is that there is an emphasis on the need for assessment both of cognitive capacity, which is the IQ, and adaptive functioning. Now, we always did cognitive capacity testing for children with mental retardation or suspected mental retardation in the past. However, now it is absolutely critical to formally assess the child's adaptive functioning, which is basically their ability to function in day-to-day life to the degree to which they're expected to. So the reason that we do both testing of cognitive capacity and adaptive functioning now is because the way that we classify intellectual disability as far as its severity is concerned is no longer on cognitive capacity, which was, as far as IQ, that's how we determine the severity of mental retardation, mild, profound, etc. Now we assess the severity of mental retardation, now intellectual disability, based on the patient's adaptive functioning. And that's based on the fact that there's a wide range of IQs, there's a wide range of adaptive functioning, and it's really the adaptive functioning that's more important for the patient's prognosis than the IQ. You can have a patient with an IQ of 50 who has better adaptive functioning perhaps than a patient with an IQ of 75. And it's really the adaptive functioning that is more important than the cognitive capacity, and that's just for practical, pragmatic purposes. We've also reorganized the disorders that pertain to autism. They're now the autism spectrum disorders. A lot of these disorders are associated with autism, but it really didn't make a whole lot of sense to have autism and any of these other disorders because we knew that these other disorders had similar features to autism, and so now we classify them under the autism spectrum disorders. There's really no autism anymore, it's just autism spectrum disorder, and then you can also have one of the associated disorders which fall under the autism spectrum disorders. You can see a lot of what we've done with the DSM-5 has pretty much been reorganizing, reclassifying, not as much of changing the criteria. There has been a little bit of that, but for the most part, we have just reorganized and reclassified. That's really been what the DSM-5 is all about. It drives me nuts too, just to have to remember those technicalities, but probably for the future, in the long run, it's probably for the best. Rett syndrome is still a pervasive developmental disorder. It's still a very recognized clinical entity. This is a disorder that is linked to the X chromosome. However, unlike most X chromosomal disorders, which we see almost exclusively in males, Rett syndrome is an X chromosomal disorder that we see almost exclusively in females. Why is that? Because females have two X chromosomes. One of them is mutated. They actually produce enough of this protein, which is the product of the mutated gene, to where they can survive to some extent. Whereas with males, if they have the mutation, they have absolutely none of this protein, and that tends to lead to fetal demise. So Rett syndrome, because we know the genetic mutation now and the molecular etiology, it has been removed from the DSM. And even though this has long been considered part of the autism spectrum, and it produces symptoms similar to autism, and it still is under the classification of pervasive developmental disorders as autism is, it is no longer in the DSM. Communication disorders, we have had some reorganization, renaming here. Language disorder is now an umbrella disorder that combines the expressive and mixed receptive expressive language disorders. Speech sound disorder has been renamed from phonological disorder. It's now called speech sound disorder. Child onset fluency disorder is just a new term, a new name, the new name for stuttering. And social pragmatic communication disorder is a new disorder, and it's referring to persistent difficulties in the social uses of verbal and nonverbal communication. So these children are not necessarily delayed in their ability to use language. The problem here is their ability to use language in a socially appropriate manner. As you can imagine, because these children have issues with language, it's going to be very important to differentiate this from autism spectrum disorder, because social communication deficits are one component of the autism spectrum disorders. All right, and we'll talk more about that, but for the most part, you should know that that autism spectrum disorder is much more than simply communication deficits. So social pragmatic communication disorder is characterized by several criteria. However, the most important one to remember is that there are persistent difficulties in the social use of verbal and nonverbal communication as manifested by the following. Don't memorize these, just get an idea here. So first is deficits in using communication for social purposes, such as greeting and sharing information in a manner appropriate for the social context. Now, I will preface here that these criteria, these abilities, they develop with age. So the way you expect a 2-year-old to communicate is completely different than the way you expect a 12-year-old to communicate. We acquire different abilities in our language, in our ability to perceive language and understand it and process it. All of that stuff develops with time. And so if you are evaluating a 3 or a 4-year-old, you're going to have to consider that much differently than you would consider a 12 or 13-year-old for that matter. So deficits in using communication for social purposes, such as greeting and sharing information in a manner appropriate for social context, that will usually manifest pretty early. Impairment of the ability to change communication to match context or the needs of the listener, such as speaking differently in a classroom than on a playground, talking differently to a child and an adult, and avoiding the use of overly formal language. So you can see that this is something that will probably come about a little bit later. This skill is matched probably with a 5, 6, 7-year-old. They'll develop it around that age, maybe a little bit earlier. Also, you can see here this last part, avoiding use of overly formal language. Where do we see that? We see avoiding use of what we see is the use of overly formal language. We see that in Asperger syndrome. So you can see that there are some overlaps here with the autism spectrum disorders, but the difference is with social communication disorder, what you have is exclusively difficulties with language. It doesn't interfere elsewhere as the autism spectrum disorders do. Difficulties following rules for conversation and storytelling, such as taking turns in conversation, rephrasing when misunderstood, and knowing how to use verbal and nonverbal signals to regulate interaction. You can see again here, more sophisticated skills. So we don't expect to see these in a normal 4-year-old. All right, so if you have a 4-year-old and you're evaluating them for social communication disorder, you're not going to expect to see this anyway. And then finally, difficulties understanding what is not explicitly stated and non-literal or ambiguous meanings of language. Here we're getting more into formal operations. So if you read Piaget, you'll see that this is something that does not happen until much later. Here we're talking early adolescence. So you tell a child, what's one to use? No use crying over spilt milk. Certainly a 7-year-old is going to take that literally, and that's fine. But by the time a child hits 12, 13, 14 years old, they should understand the meaning of idioms and figures of speech and things such as that, okay? So all this stuff just it develops gradually, and we have a general idea, an age range of how these things develop, much like, motor development and social development in young children. This develops during childhood and early adolescence. And so we have an idea of when these things sort of start to come into play in normal children. The difference is with social communication disorder, it is either delayed or absent. Okay, so besides the persistent difficulties in the social use of verbal and nonverbal communication, we have 3 other criteria. Criterion B, the deficits result in functional limitations in effective communication, and then the things consequential to them, such as social participation, social relationships, academic achievement or occupational performance, individually or in combination. Criterion C, the onset of symptoms is in the early developmental period, so they start. You see signs of this early on. However, these other factors, these other parts of criterion A, they may not and generally are not evident until later in life, because we don't expect a 4-year-old to understand "don't cry over spilt milk." We expect them to take that literally. And then finally, criterion D is that the symptoms are not attributable to another medical or neurological condition or to low abilities in the domains of word structure and grammar, and are not better explained by autism spectrum disorder, intellectual disability, global developmental delay, or another medical disorder, or mental disorder, sorry. So the one we're really looking at here is autism spectrum disorder, because language issues are such a salient feature of autism spectrum disorders, especially Asperger syndrome, where you don't see as much of the behavioral differences that you see in autism spectrum disorder. So what are you going to think of that's going to help you differentiate social communication disorder from full-on autism spectrum disorder? Things such as the presence of restrictive or repetitive behavioral patterns, lining things up early on in age. That's going to help you differentiate out social communication disorder, which is restricted to language, from the more pervasive autism spectrum disorder, and to a lesser degree, Asperger's disorder as well. Some general principles of child psychiatry. As in anywhere in pediatrics, pediatricians will tell you that children are not small adults, and that is true. Their metabolism is different, their sleep patterns are different, and also their psychiatry is different. So children are not small adults. If you're an internist and you're going to answer pediatric questions, you need to get your pediatrician hat on, because you cannot transpose children into adult medicine. Various stages of development are present from infant to adult, which we classically define as 18, but really child development continues on into the mid-20s. The brain isn't really finished developing until around age 23 to 25. So I talk about all these various stages of development in the developmental pediatrics section. You can go and watch there. I talk about the social and motor and cognitive development from age birth to 5. Talk about childhood development, adolescent development, so you can get a healthy dose of that there. Also, children tend to experience a similar spectrum of psychiatric illnesses. However, the symptoms will usually be different. And then finally, family therapy is going to play a prominent role in treatment, and that makes sense. The child is part of a family, and the parents play a big role, or hopefully play a big role, in the child's development. And so it's going to be important that mom and dad, and to a lesser extent brothers and sisters, are aware of what's going on if there's something grossly abnormal, and that this is going to help them function to get family therapy. So we'll talk about the following psychiatric disorders in children. We'll talk about disorders of cognition, which include the newly named intellectual disability. And then we'll also talk about learning disorder. Now, in the previous version of these psychiatry lectures, I actually did collapse learning disorder all into one. And that is indeed how the DSM-5 approaches it now. So it used to be there was reading disorder, writing disorder, and mathematic disorder. These have now all been collapsed into learning disorder with specifiers for these various domains. We'll talk about the pervasive developmental disorders. The DSM-5, I don't believe, uses the name pervasive developmental disorders. That is a name, though, used to classify these disorders in general pediatrics. So the autism spectrum disorder includes autism, Asperger syndrome, and childhood disintegrative disorder. We'll also talk about Rett syndrome, and even though Rett syndrome is no longer a part of DSM-5, it is part of the pervasive developmental disorders, and so since we're talking about the other pervasive developmental disorders, I thought it would be neglectful not to talk about Rett syndrome. And then we'll talk about some behavioral disorders, which include ADHD, a very common thing to see if you're working family practice or pediatrics. Kids get a note from teacher, goes over to parent freaks out, brings their kid in, concerned about ADHD, and oftentimes we do medicate these children for better or for worse. There are times it's appropriate, there's times it's not. I'm of the belief that we tend to over-medicate children. Oppositional defiant disorder and conduct disorder are two closely linked disorders that we worry about in young children. They don't tend to develop sociopathic personality disorder, however, it is a possibility. I'm sorry, I should call that antisocial personality disorder. You probably know me by now and know that I am not one to glom on to new names for disorders. It's going to take me a long time to refer to it as intellectual disability and not accidentally have a slip of the tongue and call it mental retardation. So forgive me in the future. I am trying my best, I promise. Tourette syndrome is another thing that you can see in children and certainly adults as well. This is going to be very concerning for the parent, and so you'll want to be aware of this. And then some other psychiatric disorders, including childhood enuresis and childhood anxieties. Separation anxiety being a big one. Remember now that the DSM-5 now allows you to diagnose separation anxiety in adults too. That's a good thing. Okay, so intellectual disability is diagnosed as a clinical feature characterized by impairment or deficit in two or more adaptive behaviors. So this is the same slide with some minor edits that I used in the earlier version, and the DSM-4-TR considered intellectual disability as primarily a deficit in adaptive behaviors. So it makes perfect sense now that we determine the severity not on IQ, but on adaptive capacity. So what are these adaptive behaviors? They're the activities of daily living, such as dressing oneself, bathing, toilet training, and so forth. Remember that if you are assessing a child, you need to make sure that you're assessing them proper to their age. We don't expect a 2-year-old to be able to use the toilet. We don't expect a 3-year-old to completely dress themselves. So keep that in mind. Social skills, again, appropriate to the age. Adequately interacting with others, and so forth. Communication skills, again, you have a wide range of development from age 2, 3 when you really start to talk, all the way on to 12, 13, 14 when you start to develop these formal language skills. So again, you need to assess this based on the patient's age. Generally, intellectual disability is due to genetic or chromosomal abnormalities, particularly Down syndrome, Cri du Chat syndrome, Fragile X syndrome. Sometimes can be antenatal, especially fetal alcohol syndrome or the infectious diseases falling under the category of TORCH. Rarely it is due to postnatal causes. Things that we consider here heavy metal toxicity, although we do not see that anymore. You do see it in some locales, especially where the homes are older. So you really can just look it up. I think you can look it up on certain government websites based on the patient's zip code. And that gives you an idea of how old the houses are in that area. Older houses tend to have lead paint. And children, if they get around lead paint, they're actually going to really enjoy it because lead has a sort of sweet flavor to it. They start gnawing on that, they get lead, and then you can develop mental issues from that. Head trauma, of course, can cause mental issues. Hypoxia, and then chronic uncontrolled seizure disorder. Sort of going back to hypoxia, if you have seizures, you can stop breathing, and that's going to lead to hypoxia and then brain damage from that. Traditionally, in order to diagnose intellectual disability, you have to have an IQ of less than 70. Generally, patients who have an intellectual disability will have an IQ under 70. However, now the severity is determined based on the patient's adaptive capacity. So this criteria of IQ is now obsolete. However, it is good to know for historical purposes, and generally this tends to be where the IQs fall in patients where you're choosing mild, moderate, severe, or profound intellectual disability. However, these are not strict rules anymore. The diagnosis of intellectual disability is clinical. Of course, we want to have formal testing, both for cognitive skills, which is your IQ test, as well as adaptive capacity. However, the diagnosis is still clinical. You want to assess for a cause based on history and presentation. So what are some of these causes? Some of the big causes are genetic. So it's always useful to get a karyotype for diagnosis when you suspect one of the following. So Down syndrome, of course, a lot of times now, since we have prenatal testing, Down syndrome can be diagnosed on quad screen, or at least heavily suspected. What do we see in patients with Down syndrome? We see the epicanthal fold around the medial aspect of the eye, hypotonia at birth, macroglossia or tongue protrusion, which is ultimately going to cause speech issues. And then you can also see atrioseptal defects if you're intelligent and good with your clinical practice and know you got a patient with Down syndrome, newly diagnosed, you are getting an echocardiogram. Cri du Chat Syndrome is much less common. There's characteristic cry. They say it's like a cat cry, and that's where it gets its name, Cri du Chat, meaning cat's cry. Small chin, which is known more formally as micrognathia. Repetitive movements, which is sort of like a chorea. Behavioral disturbances, and then wide-set eyes, known as hypertelorism. Typically, these patients are small when they're born. Fragile X syndrome, you see this characteristic face. It's elongated. They have a pointy chin, elongated, tall ears, joint laxity. Since these tend to be in males, you'll see macroorchidism, and then recurrent acute otitis media. Please note that nearly half of children with Fragile X syndrome will also meet the criteria for autism spectrum disorder. And you will classify this differently. They still will be diagnosed autism spectrum disorder, but you'll put autism spectrum disorder related to Fragile X syndrome. And patients with Down syndrome can have autism spectrum disorder as well. So you would just note that, yes, this patient has autism spectrum disorder, but it is associated with Fragile X syndrome or Down syndrome or whatever it's in conjunction with. There are a lot of disorders that are associated with autism. And if you look at the clinical genetics section that I do, you'll see that a lot of those conditions are associated with autism features. If there's an absent or smooth philtrum, small upper lip, that should immediately tip you off to fetal alcohol syndrome. They can also have small eyes, however, that can be difficult to diagnose in very young children, and that feature isn't as omnipresent as the smooth philtrum and the small upper lip. That small upper lip will make the distance from the nose, the tip of the nose, to where the mouth seems to start in a vertical direction. It will make that area seem longer. So they'll have a smooth philtrum and sort of this long area above their lip. This is fetal alcohol syndrome. The diagnosis will be retrospective. You want to get a history from the mother. Did you use alcohol? When did you use alcohol? How much did you use? The fact of the matter is, you don't want to tell a woman this by any means, but if mom has one beer accidentally at 1 month of gestation, it's not going to cause fetal alcohol syndrome. Typically, in order to get fetal alcohol syndrome, the exposure needs to be significant. Not always, but in the vast majority of circumstances. The management for intellectual disability is occupational therapy. This is done to maximize functional ability, particularly in patients with mild intellectual disability. In those patients, if we really get a hold of this early and maximize their functional skills, these patients can typically hold down a low-skilled job, and that's very important for their self-esteem, for maximizing their independence, and overall enhancing their quality of life. Patients with moderate intellectual disability typically will require group home setting, and then severe and profound intellectual disability usually will wind up needing to be in a nursing home or some kind of more intense setting, and some of the more profound cases will be mostly vegetative. So here's Down syndrome. I do a whole talk on Down syndrome in the clinical genetics section, but you can see here that there's a wide range. So these children, you can see, look different from baby to young child, and then here we have 2 adults, and you can see that they can certainly function. Down syndrome patients can function at relatively, well, higher levels than you might think stereotypically. So this gentleman works in an office setting, and then this young man here is an orchestra conductor. So, you know, simply because they have intellectual handicaps does not mean that they're going to be consigned to a group home setting and completely dependent on everybody else. These people can have some level of functioning in the outside world, and that's important to keep in mind, especially when counseling parents. You should always give parents a realistic idea of what their child's prognosis is. Cri du Chat Syndrome is obviously much different. You see a much different facial profile. Small chin is probably the most salient feature. There's a degree of hypertelorism here, but these features will tend to get a little bit less prominent as the children get older. But you can see some children it's more prominent than others. They all tend to have this really small chin, especially this kid here. This kid has a very high degree of hypertelorism. Also note sort of a high nasal bridge here. That can make it difficult when getting fitted for glasses. And also Cri du Chat Syndrome I talk about in its own section, the 5P deletion syndrome. Fragile X syndrome typically affects males, and you can see this sort of triangular faces, especially in this gentleman here. Sort of an elongated jaw, very tall ears. Again, you see up here, see the bigger ears. They're certainly not male rotated ears, which we see in other genetic disorders, but they are large ears. And then if you were to do further examination, you would notice macroorchidism. So here's fetal alcohol syndrome. So you can kind of tell, especially in this child, but there's an absence or very, very smooth philtrum. This little girl you can kind of make out the philtrum here, but certainly in these 2 children, the philtrum is practically non-existent. And the philtrum is just that little indentation right above the middle of your upper lip. So if you were to feel that, you'd probably notice in yourself, presuming that you don't have fetal alcohol syndrome, that philtrum is pretty prominent. And in these children, it certainly will not be prominent at all. You can also note the small, very, very small upper lip in all of these children. The small eyes, it's difficult to make that out. Certainly some children will have a higher degree of it than others. But when we're talking about small eyes, what you're really going to look for is the intercanthal distance. So the horizontal distance of the eyes. Usually a better way to detect it, if you're just looking at the child, is how much of the whites of the eyes can you see. Obviously on this child you can see a lot of the whites of the eyes. Probably A and D here, you see a lot less. Alright, so moving on to learning disorders. So learning disorders, unlike mental retardation, there is a significant disturbance in the patient's cognitive abilities, but it's in a particular area of learning. So reading or writing or mathematics, and it's limited to that area. So the patient will have grade level or above grade level reading skills and grade level or above grade level writing skills, but they'll be lacking. If they're 4th grade, maybe they're at a 1st grade math level. So that's a learning disorder. It's limited to a specific realm. And in order to diagnose learning disorder, there can't be other abnormalities present that would cause disturbances in a particular area of learning. So for instance, hearing impairment. Obviously, patients who can't hear are going to have difficulties in language. They're not going to pick up language, and so they're going to have difficulty reading and writing. Patients who have visual impairment,
they're going to have difficulty reading because they can't see the letters. So instantly we need to differentiate hearing and visual impairment in any patient with a learning disorder. And the schools usually do this, but it's very important that we know that the patient that comes in with a reading, or particularly a reading, writing, or mathematics learning disorder, if we suspect that we make sure that the patient does not have a hearing or visual impairment. Turner syndrome has particular difficulty with math, but these patients also have other prominent features. These are girls that have webbed neck, short stature, and low set ears, and they have it because they have only one X chromosome, and so we diagnose this with a karyotype. Klinefelter syndrome will be boys. They will have particular difficulty with reading and writing. This one can be tricky because Klinefelter syndrome doesn't become prominent until puberty. There'll usually be hypotonia at birth, but that's about it. These patients will be a little bit taller than most, but not necessarily to the point where it's really going to stick out. At puberty, though, it'll start to become more prominent. You'll see a gynecoid, so a wide hip development, more like a female's hips. And then they'll have less relative musculature compared to other boys their age. They'll have gynecomastia, which is enlarged breasts. And you can diagnose this also with a karyotype. Anytime, though, you see a boy with reading and writing difficulties, you're going to want to differentiate out Klinefelter syndrome. Certainly, learning disorder is the most common cause of reading and writing difficulty in boys, but Klinefelter syndrome should be differentiated, especially if there's a high height percentile or hypotonia at birth. Diagnosis for learning disorder will usually be at the school because that's where you're going to see the problems in learning, and it'll be on academic achievement testing. Management is going to be special ed, so an individualized education plan. Autism. So this is a pervasive developmental disorder, so it's the first of 4 we're going to talk about. And this is characterized by severely blunted social interaction, very, very retarded language acquisition and development, could also be completely absent. Preoccupations, which are lining things up, lining books up, lining cups up, stacking things on top of each other. These kids will really like to stack blocks. They'll be preoccupied with it. They may be preoccupied with specific parts of objects, like the hands on a clock, or the keys on a keyboard, or cups, or various other things. They'll be preoccupied with certain parts of objects. This has to be diagnosed prior to age 3, and autism is idiopathic. So we don't know what causes it. There's various theories, but those aren't going to be tested on the USMLE. There is no association with vaccinations. There's a lot going out in the media about that, but that's really just sensationalism. So it is never appropriate to counsel a patient against getting a vaccine if they come in concerned about autism. Autism is often concomitant with mental retardation, so a lot of times you will see that IQ below 70, but not always. And autism does have a preponderance for patients to get epilepsy. Approximately 25 to 50% of autistic patients will develop epilepsy. So the differential here is going to include hearing impairment. So remember, patients with hearing impairment are going to have language acquisition and development problems. But that's because they don't hear the words spoken around them. So if you don't hear the words spoken around you, you're not going to learn how to speak. So the best way to differentiate a patient with hearing impairment from a patient with autism, while they both present with slowed language development, children with hearing impairment are going to enjoy social interaction. When the mom comes into the room, the child is going to cling to the mother. The child is going to have some level of separation anxiety, etc. Patients with selective mutism, they also will be very untalkative, but it will only be in certain settings. So maybe at school or around people outside of their home and so forth. Asperger syndrome is an autism spectrum disorder that we'll talk about. And these patients will have social interaction abnormalities similar to what we see in autistic patients, but in Asperger syndrome, they will always have normal language functioning abilities. Rett syndrome is seen in girls, and they also will have symptoms similar to autism, but they'll also have motor abnormalities, which include hypotonia, hand flapping, chorea, and bruxism, which is grinding of teeth. Diagnosis for autism is clinical, and the management is going to be with family counseling and education. They'll also need special education in schools, and we manage these patients with medically for their behavioral disturbances, which will give them atypical antipsychotics. So we kind of just referred to Asperger syndrome a little bit ago, and Asperger syndrome is characterized by autism-like behavior in the realm of social interactions and behaviors, but they'll have a preservation of linguistic skills, but they will have what's known as an unusual prosody. And what that is, it's sort of difficult to explain, but you may hear, and this is going to sound really awful, but this is the best way to describe it, is that when these children talk, a lot of people would say they sound kind of nerdy. So they sound like geeks. That's obviously kind of a mean way to say it, but that's the best way to describe unusual prosody that I can think of. If you look up Asperger syndrome on YouTube, you can kind of see what I'm talking about. But that's a very prominent autism-like symptom in patients with Asperger syndrome. But the most important thing is that these patients have normal linguistic skills. They may have conduct disturbances, and we can treat that with antipsychotics, but that's not always the case. Nonverbal communication will generally be disturbed, but their verbal communication is always going to be preserved, and that's how we differentiate Asperger's from autism, is that these patients have a preservation of linguistic skills. This is often called high-functioning autism, and that's just simply because these patients function well in society. They're not mentally retarded. They'll be able to hold jobs, but they may have some problems in social interactions. The differential here is going to include schizoid personality disorder. And so patients with schizoid personality disorder are going to have social interaction deficits, but patients with schizoid personality disorder are going to seem more socially detached, and they're going to have blunt reaction and indifferent behavior towards praise and criticism. And the management for Asperger syndrome is going to be social skills training. So Rett syndrome is characterized by normal development prior to 18 months of age. And then all of a sudden, these little girls, while they're normal up to 18 months of age, and they'll start walking, and they'll talk, and they'll babble like all normal babies do, after 18 months of age, you start to get these really significant symptoms. And most of them will be characteristic of autism. So these aren't the babies that never develop speaking. These patients will start talking, and they'll start walking, but then all of a sudden they'll reach a point and these symptoms or these abilities start to kind of go away. So they'll have social interaction, but then they'll hit a point and the social interaction will deteriorate, and then it'll be reduced to absent. They'll have behavioral disturbances. And what's most important is that they'll have motor disturbances. So like I said, they'll learn how to walk right around 12 months of age, which is normal, but then suddenly they'll develop ataxia. They'll have hand flapping, which a lot of times appears as wringing of the wrist, or they'll have their hands in their mouths a lot. They'll have hypotonia, they'll have spasticity, and they'll have teeth grinding, which is bruxism. This is only in girls, and the reason is because while Rett syndrome can happen in boys, it almost always presents as stillbirth. The cause for Rett syndrome is neurologically complex, so we're not going to get into the details of it. And the diagnosis is usually clinical. These are normal patients up until about 18 months of age, and by the time they hit 3 years, you've got full-blown picture of autism and motor disturbances. We can definitively diagnose this in the presence of MECP2, which is a gene that's completely associated with Rett syndrome, but you don't necessarily need that. But that's in case the USMLE asks you, just know that MECP2 is associated with Rett syndrome. And then the differential is going to include autism, which does not have motor abnormalities. The management for Rett syndrome is going to be occupational therapy, physical therapy, and speech therapy to manage their symptoms. There's no cure for Rett syndrome, so really we're just giving supportive therapy. And we can use the atypical antipsychotics, as in any autism spectrum disorder, for severe behavioral disturbances. Parental counseling can also be useful here, just because these parents are going to have a lot on their hands with having to take care of these girls. Childhood disintegrative disorder, it is as depressive as it sounds. So these patients have normal development through at least age 3. It could be even as late as age 10. And then all of a sudden, you're going to have significant to complete deterioration of social interaction, language skills, control over bowel and bladder, and the development of autism-like behaviors. There will also be some degree of motor deterioration, but it won't be as prominent as in Rett syndrome. So childhood disintegrative disorder, the way to distinguish it from Rett syndrome is that it can happen in boys as well. And generally, the childhood disintegrative disorder will have an onset later than 18 months. And so it'll be at least age 3 and before age 10. So a much later onset than Rett syndrome. And the diagnosis for childhood disintegrative disorder is also clinical. The management is going to be behavioral therapy, and these patients will need long-term assisted care and atypical antipsychotics for behavioral disturbances. Okay, so this one's probably going to be the one you'll see most in the clinic out of all the ones we're going to talk about. And this is attention deficit hyperactivity disorder, otherwise known as ADHD. And what's most important to emphasize here is that it's characterized by inattentiveness, hyperactivity, or impulsivity that results in difficulty functioning in, most importantly, at least 2 settings. So these aren't the patients that can't pay attention in school but then come home and they do their chores. Or they are acting out at home but then they go to school and they're fine. They have at least 2 settings where their inattentiveness, hyperactivity, or impulsivity are causing notable problems. And the symptoms have to be present for at least 6 months, but generally you'll be able to diagnose this on the first visit that a patient comes in, because they'll say that the symptoms have been going on for a long time. ADHD is a risk factor for substance abuse and as an adolescent and adult, so important to keep that in mind. And the differential for ADHD will include age-appropriate behavior, so the best way to differentiate that out is to make sure that these aren't just behaviors that are annoying to the teacher or parent. That does happen more than you think. ADHD has to result in difficulty functioning in at least 2 settings. And we also have to differentiate this out from oppositional defiant disorder. It can be concomitant, so they could have both at the same time, but oppositional defiant disorder is much more significant. So we will actually, if we get a question and oppositional defiant disorder symptoms are most prominent, we're gonna diagnose that as opposed to the ADHD. And oppositional defiant disorder most prominently is going to include defiancy towards figures of authority and acting out. And then ADHD needs to be differentiated from any mood disorder, especially major depression. Think if you're depressed, you're not going to be wanting to pay attention very much. As a matter of fact, inattentiveness or concentration problems are a SIGI CAP symptom. So if a child is inattentive at school or at home, we might want to consider major depressive disorder, which can happen in children just like adults. And then the diagnosis is going to be clinical. So the management is going to be twofold. It's behavioral and pharmacologic. They both play important roles. We want to ensure structure and reliability in both the home and school settings. And family therapy can be useful to help mom and dad both learn skills that they can use to help their child and to help the child with their behavioral problems. And stimulants play a prominent role in therapy. Why would you want to stimulate a child with ADHD? Well, the thought is that there's a problem, a deficit in dopamine. And remember, dopamine acts on the reward pathway. So think if you have a defect or a deficit in dopamine, what are you going to do to stimulate that dopamine? You're going to engage in stimulating activities. Go stand on a chair and jump down, or wrestle with your classmate, or interrupt, or do things that are behaviorally stimulating to yourself. And so that's going to increase the dopamine. So what we think is that using these stimulants, because they are addictive and because they work on the reward pathway, we're actually increasing the dopamine. And so by increasing that dopamine, these patients now don't have to engage in these self-stimulating behaviors that are so characteristic of ADHD, and it'll be easier for them to pay attention in school and at home. The most commonly prescribed stimulant that you'll see most often on the USMLE is going to be methylphenidate, which is Ritalin. Amphetamine salts, dextroamphetamine, and others are commonly prescribed. But these three, make sure you know them. Oppositional defiant disorder. So this is a behavioral problem. And what oppositional defiant disorder is a pattern of argumentative, hostile, negative, spiteful behavior, especially towards parents and figures of authority. But what we have to make sure of is that even though this results in tantrums and acting out, this does not directly violate the rights of others. So these patients might go slam their door and they might cuss at their parents, but they're not going to push their fist into the wall. They're not going to set something on fire. They're not going to steal. They're not going to do anything that directly violates the rights of others. This does have a male preponderance, and approximately half will progress to the more severe conduct disorder, which we'll talk about next. The diagnosis is clinical based on the symptoms, and the differential is going to include ADHD. Both can show disregard for figures of authority, but the reasoning is going to be different. Patients with ADHD are going to show disregard by being inattentive or hyperactive, while patients with ODD are going to be argumentative and hostile. And then conduct disorder. Patients with conduct disorder are going to actually violate the rights of others, and that's going to be through theft, violence, and property damage. Management for ODD is positive reinforcement and praise for appropriate behaviors. Family therapy and individual behavioral therapy are also effective. So conduct disorder are behaviors similar to ODD, but in addition to ODD, they also have additional violations of rights of others, including theft, property damage, and violence. This also has a male preponderance, and the diagnosis is clinical. And this actually should say oppositional defiant disorder. Patients with oppositional defiant disorder don't directly violate the rights of others, and the problem is limited to argumentativeness, etc. The management is going to be similar to conduct disorder, and once the patient turns 18, if they still have conduct disorder, then the diagnosis is going to shift to antisocial personality disorder, which we talked about in the personality disorders section. Tourette syndrome. So this is characterized by brief involuntary vocal or motor activities, which are known as tics. So most commonly we hear this described as coprolalia, but actually less than 10% of patients with Tourette syndrome have coprolalia, which is involuntary cussing. And the hypothesis behind Tourette syndrome is that there's too much dopaminergic activity in the basal ganglia. So remember that the basal ganglia actually is responsible for inhibiting specific movements, and it's also implicated in Huntington's disease. So this will be important when we talk about the management. The diagnosis for Tourette syndrome is clinical and of exclusion. So these tics, involuntary motor activity, what does that sound like? That sounds like complex partial seizure. Complex partial seizures are involuntary motor activities. So when we suspect Tourette's, before we diagnose it, it's always a good idea to get an EEG, and that will help us see if it's complex partial seizures that are causing the motor activity, which we would treat in an entirely different way. We would treat that with anti-epileptic drugs. If it's not complex partial seizures, then we can exclude it and we would diagnose Tourette's. And the differential is going to include complex partial seizures, as I mentioned just before, and Huntington's disease, which also has tics, but it's implicated, and it's also implicated by the basal ganglia. But these patients are going to have a family history, and as far as the USMLE is concerned, you're going to have, always going to have adult onset, approximately the late 30s, early 40s. There are children with Huntington's disease, but as far as USMLE is concerned, that doesn't happen. It's always going to be adult onset for Huntington's disease. The management for Tourette syndrome is pharmacologic, and look at what the hypothesis is. Too much dopaminergic activity in the basal ganglia. This management tends to work for patients with Tourette syndrome, and we use typical or high-potency atypical antipsychotics. And what do both of these do? They inhibit dopamine. So enuresis is characterized by inappropriate voiding of urine after the age of 5, and by definition, this can't be due to a general medical condition. So enuresis can be nocturnal, which we would commonly refer to as bedwetting, or it can be diurnal. And the diagnosis is going to be clinical and of exclusion. So we want to exclude any general medical condition or other psychiatric condition before we diagnose enuresis. So two of the medical conditions, one would be ectopic ureter. So this is a surgical condition, and the urination is going to have to be nocturnal and diurnal here. So these patients are going to be constantly wet. Why are they going to be constantly wet? Well, because you have a ureter, which remember comes from the kidney, and it's going to implant not in the bladder, it's going to implant either in the urethra, or in girls it could implant in the vagina or the vaginal vault. And so because you don't have sphincter control below the bladder, you're going to have urine that just constantly drips out. And so parents will complain that these patients are constantly wet. And we can exclude this or diagnose this with a CT. Urinary tract infection, the inflammation is going to cause detrusor irritation, which will cause, in many cases, involuntary voiding. This will be an all-of-a-sudden thing. The patient will complain of pain on urination if they're old enough to talk. And we can exclude this with a urinalysis and a culture. And generally, this will abate. So you're not going to see continued enuresis once the urinary tract infection has gone away. Mental retardation, that's pretty obvious to differentiate out. An adjustment disorder, a lot of times you're going to see enuresis, particularly nocturnal enuresis, following a life-changing or difficult event, and that's just simply a regression that most children will show during adjustment disorders. Management for enuresis is going to include behavioral therapy. One thing that we have is a bell pad apparatus. I've never actually seen that used before, but it comes up in questions, so keep in mind that that exists. And avoiding large amounts of water before bed is obviously good for preventing nocturnal enuresis. Reassurance for the child, because a lot of times anxiety is going to precipitate enuresis, so reassuring the child is useful. And pharmacotherapy for acute care is DDAVP or desmopressin. And why would we want to use pharmacotherapy? Well, let's say that the patient is going to a sleepover and they don't want to be embarrassed. Well, that's a good place to give them some pharmacotherapy so that they can get through that. But definitely pharmacotherapy is not good management for long-term care. We're going to want to use behavioral therapy. The childhood anxieties, they can be normal, but if they go on too long, then they become abnormal and warrant treatment. So the most prominent childhood anxieties, which is stranger anxiety, which peaks between 8 to 24 months, and this is normal, and it's characterized simply by a fear of others outside primary caretakers. And then also separation anxiety, which peaks between 1 and 3 years, and this is characterized by a fear of separation from the primary caretakers. So one is a fear of others outside the primary caretakers, and the other is actually fear of being separated from the primary caretakers. Both stranger anxiety and separation anxiety are normal, but when separation anxiety presents in preschool or particularly in kindergarten or later, then it becomes a problem where we want to treat it, because obviously if you're having separation anxiety while you're supposed to be in school learning, then you're going to have issues at school. So the diagnosis for this is also clinical, and the management is only indicated for separation anxiety presenting in a school-aged child. Cognitive behavioral therapy is the therapy of choice. SSRIs are second line, and they're only to be used if cognitive behavioral therapy has already been attempted. And that is it.